Next up, we have Dr. Cecily Clark-Ganheart, and I'd like to introduce her to everybody today. Dr. Clark-Ganheart is a triple board certified physician in maternal fetal medicine, obstetrics and gynecology, and obesity medicine. She is the president and CEO of Prenatal Specialists of Kansas City and Conceptual Health and Wellness, a combination of high-risk obstetrics and wellness practice. Dr. Clark-Ganheart believes we cannot talk about health and wellness without discussing how racial disparities prevent people from achieving health and wellness. These disparities precede COVID and contributed to the devastating outcomes we see in Black, Indigenous, and people of color communities. Metabolic syndrome is one of the comorbidities that greatly increases the morbidity and mortality in COVID. And Dr. Clark-Ganheart will also discuss her personal journey with obesity and reversing her own metabolic syndrome by incorporating intermittent fasting and a low-carb diet. Dr. Clark-Ganheart will participate in the panel discussion at 4 p.m., where she will answer your questions about her presentation. Welcome, Dr. Clark-Ganheart.
Thank you. Thank you so much for having me. I will go ahead and share my screen here. Give me just a second so I can share my presentation. And then I'll maximize it, and then we can begin. Okay, so hopefully everyone can see that clearly. So thank you so much for that warm and kind introduction. My name is Dr. Gainhart. I'm a high-risk OB in the Kansas City area. And today I will discuss racial disparities in health and wellness. And then I will probably save some of the talk for intermittent fasting, like if people have questions about that specifically, maybe for the panel discussion, because I definitely want to make sure we have plenty of time to discuss in the presentation health and wellness and the disparities that we see and potential ways that we can start to address these items. So in terms of disclosures, the talk today is for informational purposes as well as the portion of the panel discussion. So information we discuss is not to be construed as medical advice. And I hope that we have an open dialogue discussing disparities today so that we can hopefully work forward and begin to really tackle some of these issues in society. So the objectives of my talk today are to review racial disparities in healthcare, because I think we need to understand how this also affects healthcare so we can see how this may transition into our field of health and wellness. We'll discuss racial disparities in health and wellness, and then I'd also like to talk about where do we go next? What do we do? How can we begin to tackle some of these issues? So first, everyone talks about healthcare disparities or health disparities, but what does that actually mean? When we look at definitions of health disparities, there are differences in disease burden, disability, and mortality in a defined population. And so populations can be defined in many different ways, many different groups of people. For instance, some of the most common discussion around health disparities will involve either racial or ethnic minorities, people who live in diverse geographic locations. So what do I mean by that? You can look at disparities in rural settings versus urban settings, various countries, et cetera. Looking at disparities by gender, looking at women, children. Age can play a role in disparities as well, particularly among the elderly. And then also we look at people with pre-existing disabilities. So when we're talking about disparities, we're looking at Do outcomes really differ based on the color of your skin? Do they differ based on your gender assignment at birth? Do they differ just by whether you live in a rural community versus an inner city community? Um, how are different characteristics playing a role in the disease or outcomes various communities experience? So when we're looking at examples of disparities by race and ethnicity, and I'm actually going to dive a little deeper into each of these categories, and you'll see as we progress through the presentation why I chose these to discuss. When we're looking at this, so when we're looking at our axis here, this is in rate. So is someone 4 times the rate or 3 times the rate? So that's what we're looking at in order to compare everything here. The first thing that should jump out to you on the screen is that maternal mortality has one of the greatest rates of disparity when we're looking at health indicators in the United States. My primary specialty before I also started becoming more active in health and wellness communities is high risk pregnancies. So that's maternal fetal medicine. So I would be remiss not to have a discussion on disparities include maternal mortality. As we can see, Black women in the United States are 4 times more likely to die during childbirth or immediately after compared with any other racial ethnic group in the United States. When we look at preterm delivery or preterm birth, Black women are twice as likely to have a preterm delivery. Members of the Latinx population are going to be 1.5 times at risk. When we're looking at severe obesity, depending on how it's defined, BMI of 35 or greater or BMI of 40 or greater. The rates are also increased for minority populations or racial ethnic groups as well. So we definitely need to address the statistics and briefly review why that may be within healthcare before transitioning to health and wellness. So as I alluded to earlier, the United States has a problem with maternal mortality. In fact, the United States ranks last among industrialized nations in this category. So how do we define maternal death? It is defined as death that occurs within 1 year of pregnancy, and it's either caused by a pregnancy complication or a chain of events that were initiated by pregnancy. So postpartum hemorrhage could be an example of that. You can't have a postpartum hemorrhage if you weren't pregnant to begin with. Or it can be the aggravation of an unrelated condition by the physiologic effects of pregnancy. So what does that mean? So for instance, let's say that someone is pregnant with a pre-existing condition like heart failure, for example. You can have changes in pregnancy that worsen heart disease. And so that's what that last line is getting at there. Over the past 2 decades, maternal mortality rates have actually declined around the world, which is wonderful. However, that's not the case in the United States. In the United States, maternal mortality rates have actually increased for all racial ethnic groups. However, the gap between Black and white patients have widened the most over the last 100 years. So we should pause and think about that for a second. That means just a few years after women gained the right to vote, maybe about 65 years post-slavery, the gap between maternal mortality for Black and white individuals was actually less than what it is today. And when you think about that, that really should have us kind of sit back and really want to delve deeper into why is that? When we look at maternal mortality, leading causes include hypertension, cardiovascular complications, infection, and hemorrhage. I've alluded to already that non-Hispanic Black women have the fastest rate of increase, and that rate has increased drastically between 2007 and 2014. Depending on where in the United States, maternal mortality rates for Black women are 12 times higher that of their white counterparts, meaning that there are some locations in the United States where death rates for Black mothers is going to be higher than in developing nations. Disparities also exist among Native American, Indigenous populations, Asian, and some Latinx populations. Out of this group, the next highest group for maternal mortality would be that of Indigenous or Native American populations in the United States. The most striking thing about maternal mortality, at least from a maternal fetal medicine point of view, is that it's largely preventable. So when we actually go back and do like root cause analysis, that's what we're supposed to do after a sentinel event. Hopefully every hospital system is doing that and not just saying, oh, well, I guess we couldn't have done anything differently, because a lot of times there are things that could have been done. And so when we look at it being preventable, I think that's one of the things that really hits home and really underlines the systemic biases that are present in the healthcare system. And depending on the region and depending on the study, um, some statistics show that maternal mortality in Black women, up to 90% of those deaths were actually preventable. And that would make sense if we're missing out on opportunities in Black women to prevent death greater than other racial ethnic groups. That would make sense then why maternal mortality among Black women in the United States would be at some of the highest levels. Um, Original theories suggested maternal mortality was due to unequal access of care or socioeconomic economic factors, less well educated or in poor communities or various demographic factors. Quite honestly, that's victim blaming, and you're blaming the patient for their own outcome in terms of the healthcare field, rather than addressing that maybe it's not because she didn't have a college degree, that's why the mom passed away. What mechanisms were in place or what steps failed to prevent this maternal death rather than trying to explain it away? And the next slide, we'll get into that in a little more detail. So I'm not sure if you all heard of Dr. Wallace. Dr. Wallace's story was in the news quite a bit earlier in the year. It was on various social media channels. Dr. Wallace was a chief pediatric resident in Indiana. So that's where we're going to get at this next statement, where we talk about even after controlling for socioeconomic factors, Black women are still at increased risk of maternal mortality. So for those who are unfamiliar with the medical education system, we have college and then medical school, and then you have residency. And that's before you can practice independently as a physician. So when we talk about a chief resident, that is someone who is in their last year of residency. And to actually get the designation of not just being, a senior resident, but to be the chief, typically that is someone who is very high performing, both academically, clinically, and socially, so that they're entrusted in that role of supervising other residents. So Dr. Wallace died of HELLP syndrome. HELLP syndrome is something that, if it's recognized promptly, is actually very treatable. We can assume that her being a chief resident, she was not of a lower socioeconomic status. She was likely very compliant in her care, being in the healthcare field, knowing how important it is to follow up. And yet she still experienced maternal mortality. A college educated Black woman is at 60% greater risk of maternal death compared to white or Latinx populations without a high school degree. So even after getting education, even after obtaining wealth, even after having all of these different experiences, the disparity is still there. And that's what this graph shows from one of the articles cited in my presentation today that does look at, well, is it really socioeconomic status or is it something else? And so when we look at high school, less than high school, some college, the disparities still exist. And that introduces things as possible explanations as systemic biases in the healthcare system. Now, for maternal mortality, when we look at maternal mortality, a lot of people consider that metric as a tip of the iceberg, meaning that for every maternal death that there are lots of near misses in terms of, goodness, we dodged a bullet that time, right? And so yearly, more than 60,000 women experience severe morbidity in the United States. Again, the United States as a whole is failing women when it comes to maternity care. And we're failing some ethnic groups even at greater or more drastic rates, particularly that of Black women. The rise of maternal near misses, or what we also call severe maternal morbidity, has paralleled the increase of maternal mortality. And that would make sense. That would make complete sense in that realm. And so you can see some of the percentage rate increases since 1997 in just severe maternal morbidity as well. So now looking at preterm birth. So preterm birth is also a public health issue, and we should discuss that as well. For those unfamiliar with preterm delivery or preterm birth, that's delivery occurring less than 37 weeks of gestation. Very preterm gestations, depending on the study you use or the metric to define that, would be considered delivery less than 32 weeks of gestation. But you can also break that down as deliveries less than 28 weeks, and then periviable deliveries that occur, depending on where you're at in the country, between 22 and 25 weeks of gestation. So why am I taking a moment to talk about this at all? Well, the reason I would like to talk about it is because, one, infants born prematurely are at increased risk of morbidity and mortality. Preterm delivery is a direct cause of newborn death in 35% of cases worldwide. But the key that I would like us to think about when we're talking about preterm delivery is that a premature birth places that child at increased risk of complications throughout life. So it's the intrauterine environment, and you may be familiar with the study of epigenetics that talks about that, how fetal programming inside of the womb, the exposures that are there, the health status of the mom can then predispose children and for the rest of their adult lives to various conditions or outcomes. So when we look at preterm delivery, we want to also think about the impacts that this has on a child, not only in the immediate period, whether they get admitted to the NICU or not, but we're talking about years to come and possibly throughout life. So studies have consistently demonstrated that Black women also have an increased rate of preterm delivery less than 37 weeks. Data for additional and other racial ethnic groups are mixed. Some studies show that there's increased rates, some don't. And so that's when we start looking, at the confidence intervals here. For those who are familiar with confidence intervals, when we're talking about the increased odds of something happening or increased risk, if the confidence interval does not include one for statistical purposes, then it is likely that there actually is a true difference there. And the further you get away from one, the likelihood that a difference does exist. When it does cross one, as you see in the intervals for that Latinx and Asian populations, you will see that does include one. And so that shows that some studies have shown differences, but then there are also studies that have not. But it's definitely something we need to be mindful are, again, for women in general, keeping our eyes on that preterm delivery rate. Now, when we start to get into less than 34 weeks of gestation and less than 32 weeks gestation, again, the differences between Black and white become even more pronounced. This is particularly problematic because when you're getting below 32 weeks, these are the infants that are going to be at greatest risk for long-term complications that are going to persist through life. And so what are some of those complications? So when we talk about extreme prematurity, we're having increased risk of brain bleeds, that's intraventricular hemorrhage, respiratory issues, retinopathy, meaning vision problems, and even blindness, sepsis, critical infections, necrotizing enterocolitis, that's a bowel-specific condition, reduced breastfeeding rates. Breastfeeding is important. We won't necessarily have time to go into that today, but breastfeeding provides so many benefits, health benefits, microbiome benefits, brain benefits. That is something important to consider as well. And then also cerebral palsy. So disparities of care beginning in the womb in terms of treatment or prenatal care and quality of care that mothers are receiving, that again, through the study of epigenetics, shows that the experience that a child has prior to delivery can in itself impact future expression of disease and et cetera. So you're combining that and then also adding extreme prematurity on top of that. And the two together can have a profound impact on long-term outcome. When we're looking at NICU care, so then to add even more, and now it's a triple whammy, I guess, if you would look at it like that, we're looking at NICU care. So NICU care, we really need, amazing NICUs to help care for these extreme preterm infants so that we can decrease the impact of prematurity on these children for the rest of their lives. But when we look at it, studies have shown that even in NICU care, infants are segregated and relegated and delegated to NICUs based on their racial ethnic status, with Black infants being more likely to have concentration at NICUs with lower quality scores. So if you're receiving a lower quality of care and you're more likely to have that based on race, and we're already experiencing extreme prematurity and already experiencing things prior to birth, that again is just going to keep compounding outcome for these populations. The study also showed that patients that identified either as Hispanic or Latinx or Asian infants were more likely to have concentrations in NICUs with higher quality scores, along with patients who identified as Caucasian American. Regional differences based on population, segregation. So it's difficult to separate biases outside of the hospital from within the hospital. As much as we would like to believe that personal beliefs and whatnot, we check them all at the door and it doesn't affect care, it does affect care. And we're going to also discuss this in terms of health and wellness. The health and wellness community is not, immune to personal preferences, personal thoughts. All of that plays a role into how care is delivered. When we look at infant mortality rates, that's another indicator of kind of societal health. So again, we look at maternal mortality as an aspect of societal health among industrialized nations. Um, we rank, unfortunately, among the last, when I say we, I mean in the United States, rank last compared to most industrialized nations. NICU care has been shown to be segregated and unequal. And some studies, again, depending on the different group of Latinx populations. So, for instance, studies have shown that Puerto Rican Americans are more likely to be segregated to lower NICU facilities compared to other groups. So, when we start to really pick it apart, we can see that there are these variations based on race and ethnicity. There's variations based on within ethnic groups, depending on what their specific ethnicity is. And it's something that definitely we need to continue to identify these differences, because if we're unaware that these differences exist, then we can't find ways to actually address them. So before we get into the health and wellness portion, I wanted to end on obesity because it is a bridge. Obesity is a metric that we use in healthcare, but it's also a metric that we also like to tackle from a health and wellness perspective. And so I thought this would be a nice segue into the latter part of the talk. So when we're speaking of obesity, let's first make sure we're on the same page and how it's defined. We probably already are, but let's go ahead and just discuss that briefly. So various classifications exist. So yes, let's acknowledge right off the bat that BMI is not the best way to measure obesity. However, this is what the studies have used in research for time and time again. And so as much as we would like to just disregard all talk of obesity, or I'm sorry, all talk of BMI as it relates to obesity, it's going to be here for a while because that's how the studies were defined. So problems with BMI though that we should acknowledge. BMI tends to overestimate body fat in Black women, and it tends to underestimate the impact of obesity in Asian populations. Different cutoffs for obesity by BMI is actually recommended in Asian populations compared to Black, white, and Hispanic populations. Waist circumference is likely a more appropriate indicator of obesity. And you can see the various cutoffs on the screen. Again, just as in we should be using more stringent criteria for BMI in populations of Asian background, the waist circumference measurements should also be adjusted based on Asian race as well. However, we do need to acknowledge that over a certain BMI, unless you are a bodybuilder or professional athlete, um, once you hit BMIs, especially over 40, either waist circumference or that BMI number still are predictive of increased risk for adverse health outcomes, which is why the initial slide talked about severe obesity, because again, over a BMI of 40, unless you fall into those populations of athlete or extreme bodybuilder, you are definitely having an increased risk of adverse health outcomes. So when we're looking at rates of obesity in the United States in general, we're just going in the wrong direction. We have various initiatives to try to decrease that, but unfortunately, right now, as a nation, we are losing the battle with obesity, and things are only getting worse. When we look across different racial ethnic groups, you can see differences here by race and ethnicity. When we look at how just obesity has been increasing in the United States in general, if we look at between the time period of 1999 to 2000, the prevalence was about 30.5%. Most recently, when we looked at metrics from 2017 to 2018, that had increased to just shy of 43%. Over the same time period, severe obesity has also increased from 4.7% to 9.2%. So again, it's something that we have to be cognizant of. When we look at breakdown by state, I just wanted to, point this out, just how we're increasing in general. Um, Both Southern and Midwestern regions are having the greatest rise of obesity, with these areas having greater than or equal to 35% of the population being obese. And again, these rates are only climbing. So, except for Black women, prevalence of obesity did not differ drastically between non-Hispanic Black groups or white groups. It didn't necessarily reach statistical significance either for Latinx populations. Lowest rates of obesity are found among Asian populations in this country. But the issue with obesity is that when patients experience obesity related complications, outcomes are still worse for racial ethnic groups. So even if the rates are similar, the impact of obesity has a more profound effect on group of color. So for example, Blacks are 30% more likely to die from heart disease, twice as likely to experience stroke, less likely to receive life-saving reperfusion therapy. So basically, less likely to receive treatment in a proper fashion for the heart attack, and are less likely to receive therapy for added control of hypertension when compared to all racial ethnic groups in the United States. And so, because of the disparities that we've talked about, and obviously there are many others, but for interest of time, we can't go into all of them. This is why the health and wellness field is so important. But when we turn to health and wellness, do we still find disparities there that then may decrease the access to individuals truly being able to reach health and wellness independent of the medical system that seems to be failing many people at this time? So when we talk about disparities in health and wellness, we first need to turn our attention to the fact that the health and wellness industry, there's so much money pumped into this industry. Everyone talks about the healthcare system, but $4.5 trillion are spent in health and wellness. And so wellness, though, unfortunately, isn't always welcoming. This was an article that was in Today. Again, the reference will be in my slide. But what has become increasingly clear over the last several years, and mind you, these aren't new problems, it's just that we are now talking about some of these issues. Diversity is lacking. And again, diversity doesn't just mean Black, white. Diversity is a whole host of things. So yes, wellness lacks racial and ethnic representation, but it also lacks different body types. Typically, when someone thinks of wellness, you may have a stereotypic size that pops into mind versus do you necessarily see women of larger body types being promoted as yoga instructors, things like that? Probably not. So we have to keep that in mind. Sexual orientation, socioeconomic diversity is lacking, and then access to health and wellness in different geographic areas. How many yoga studios are in rural areas? How many yoga studios are in inner city areas? Again, there it can be disparities in a range of different categories and all need addressing. So we've already talked about earlier that in dietetics, um, that representation is lacking. And that is important because if we're telling someone that they need to clean up their diet, but we're not telling them how to do that in a way that fits within their cultural norms, then that's not necessarily going to be realistic. We can't tell everyone to eat the same thing because we all come from different backgrounds. And there's little education within nutrition for practitioners to be able to tailor nutrition to a cultural specific form. So that is a problem with not having as much representation of various backgrounds. It seems like it's starting to improve in some racial ethnic groups and worsening in others. And so this is why it's going to be important to have resources available to just integrate this into training in general so that someone from African American background could have a conversation about nutrition with someone from an Asian background and be able to help troubleshoot cultural specific ways to address the nutrition and how to improve that. So where do we go next? If anything, 2020, even though we're into 2021, demonstrated that great rifts in general society exist. So, contrary to popular belief, 2020 didn't just create these rifts, okay? These things were happening before 20 and 20, but maybe it just wasn't thought to be polite to talk about these things, or we kind of swept them under the rug. But as we continue to sweep societal issues under the rug, disparities then become worse. So we have to address these things. People began having uncomfortable conversations about police brutality. Inequities of the healthcare system were just cracked even more as a result of COVID. We saw increase in hate crimes and hate speech. The online wellness community was not shielded from the things that were going on in society. And it actually showed that the wellness community is very socially unwell. There's lots of divisive rhetoric, polarizing behavior, and hate speech, even among many social media channels. So on Instagram, I'm known as the fasting doctor, and I can tell you there was just an uptick in all sorts of different speech being posted on various platforms under the guise of freedom of speech. But it's really hateful speech. Where we can go from here, so it is a multifactorial problem. Rome wasn't built in a day. And so it's going to take many different people and different organizations having different focuses to really start to tackle this. And personally, we all need to individually start to do a little self-reflection, see what we can do. So we'll go through this a little more in detail where we talk about how we can learn, research, support, community engagement, and have culturally specific resources to target some of these items. In terms of suggestions, so learning involves having diverse experiences. We can start conversations, even reaching out to someone of a different background than yourself. And this goes for ethnic minorities and non-ethnic minorities. Learning about other people and just having a genuine relationship with someone helps you see a broader view of all people. We don't want to start to develop this self-guilt. You know, I'll talk with people and they talk about how it's difficult to discuss some of these issues because it makes them feel bad or guilty about the role that they're playing. But it's not about being guilty, it's about changing the behavior and looking at different ways to become more culturally competent. Research is also needed to look at disparities in health and wellness. So, yes, disparities do exist. For example, if people hadn't have researched and actually broken out responses by race, we would have never known that a common blood pressure medication called an ACE inhibitor should not be used as the only blood pressure medication among Blacks because it controls hypertension worse compared to something like a nifedipine. So again, you have to also do research into specific groups that you're trying to target. Support, we've already talked about how representation matters. And representation is not only ethnic diversity, it is a myriad of things such as body type, et cetera. Community engagement, having more nonprofit organizations delve into different locations and trying to bring programming to those communities. So it does no well to market to a rural community and tell them about a program that's happening 45 minutes away from them, right? Same thing with an urban community. It doesn't make sense to pass out flyers and then tell them to come and drive to the suburbs. So keeping those type of things in mind, especially when we're delving more closely into cultural specific resources, because some of the healthcare fields may be have lower representation, it makes sense that then the health and wellness community also needs to be aware of culturally specific resources where people can see themselves in the recipes and things that are being promoted. We also need to approach the whole person. So when we talk about I don't see color and we tell people to be grateful and express gratitude, don't worry, be happy, do affirmations. Well, I think you have to acknowledge the social stressors that are going on. You know, how can I not forget about the things that are going on in society? But how can wellness help me to be able to better prepare to deal with what's going on? Because when we talk about being gratitude, it's almost like if we talk about that things need improving in society, that we're not grateful. You can be grateful to be alive and recognize the social stressors that need addressing in society at the same time. The two are not mutually exclusive. Also, when we talk about lifestyle changes, and we can get into this more in the panel discussion, probably for the interest of time, but just briefly, you see in the shaded out background, that is a famous football player, Cristiano Ronaldo. And when I say football, I mean American soccer, football worldwide, where he, in a recent press conference, much to Coca-Cola's stock prices dismay, removed all the Coke from the podium during the press conference. And he has said, drink water, just drink water. And so we need to be able to start to meet people with realistic and simple changes that we can do. One is stop drinking pop, stop drinking juice, drink more water. When we tell someone to eat more plants, well, are plants in grocery stores available in that area? That's why community gardens are key. Increase physical activity. Everyone can't go to the gym. It's not an excuse, everyone can't go to the gym. So, what can we do in their own lives to increase physical activity? Intermittent fasting. We come from a culture where you eat everything on your plate. Well, let's talk about fasting between meals. And I've already talked about the increased water intake. And then when we talk about mindfulness, mindfulness does not mean forget your problems and not to address the things in society that are going on. But how can we use mindfulness to help us be able to reduce the hold that some of those things have on us? So, in summary, we need to acknowledge disparities, and that's key because if we don't acknowledge them, we can't address them. And if we don't address them, we can't make an impact. We need to recognize that healthcare disparities exist, but also disparities in wellness. We need to create more inclusive environments, and we need to recognize our own biases so that we can truly begin to promote wellness for all. And as we become more well, we'll need to depend on the healthcare system less. These are a summary of my references. If anyone would like a complete list, I can definitely provide that so that you can have that emailed. Um, and I'd like to thank you. And if anyone has any questions, we can discuss that now. We're on the panel discussion. So thank you very much for allowing me to have the opportunity to speak.